Hello, everybody. Welcome to another episode of Accreditation TV. We're going to do something a little different today. I know we had said that this particular episode was going to be about um, loaner equipment, demo equipment, and we decided to preempt that and do something a little bit different based on the fact that we're getting a lot of questions and seeing a lot of folks that are using risk assessments out there right now. And it seems to be sort of a hot topic, and we just wanted to address it because we think a lot of people are either using them or talking about them or wanting to use them right now. So we're going to get to that demo loaner equipment next episode here in 2 weeks. So we apologize for that switch, but we felt like we would want to get this one up front. So thanks again for joining us today. Really quickly, some housekeeping, then I'll introduce our guest. First of all, it's something that I screwed up the last time. Honestly, I said, if you got questions, put them in the chat. Don't put them in the chat. There's actually a separate Q&A button. If you'll push that, that allows us to respond to you directly. We had a little problem with that in the last one, so my bust. So please, if you'll do that. Also, if you're one of our Accreditation Readiness Network members and you're wanting to get your CECs, let us know. Happy to do that for you. And if you're not an Accreditation Readiness Network member, let us know. We'll be happy to talk to you about that. So let me introduce our two guests today, which everybody already probably knows, but I will start with Dr. Edwin Lofton, our clinical representative. So thank you for joining us today. He's going to kind of bring that clinical perspective to it. And then we have Skip Smith, who has been past president of ASHE, been around quite a bit, managed a bunch of hospitals, and has been with MSL for quite a while now. I didn't realize how long until we were talking about it last week, but welcome both here. I appreciate you both giving us some time today. So let's just kind of talk through this whole risk assessment thing, right? So what prompted this preemption? That was a lot of P's. Is the fact that we're one is we've been getting a lot of questions about using risk assessments. Two, we see a lot of those out when we're out doing surveys. And so in many respects, kind of a proactive risk assessment has become a little bit of a get out of jail free card in some respects, but it's also a very valuable tool for helping situations where a situation might be technically infeasible to correct, particularly for code deficiencies. And then if we have time, I want to kind of talk a little bit about functional risk assessments in terms of construction planning and that sort of thing. But I know Skip and I had a little bit of a difference of opinion about risk assessments, and so hopefully we'll get to that. But thanks guys for jumping in. Let's just kind of talk through, like, Skip, I know you and I have experienced this quite a bit, particularly with code deficiencies, where we'll come across something that's a life safety code issue, or maybe it's a building code issues, typically more life safety code issues, where hospitals decide, well, we can't really fix that. Let's do a proactive risk assessment and get that documented, and we'll use that as our defensible position during our next survey. So tell me a little bit about how you approach that, for one, and I can see by the smile on your face you want to talk about how we have a little bit of a difference sometimes in how we approach that. So
And let the debate begin. So, so yes, I think that there is an overuse of the risk assessment at this point. So I will agree with you about that. Where I think that it tends to lose the term meaningfulness is we just check the box. Yes, we did a risk assessment and we put it on the shelf. And so when the Joint Commission shows up, look, we assessed this risk against the standard and decided this is what we're going to do. That is not meaningful. That is literally just check the box, I did this. The meaningful part is when you do the risk assessment, what is the issue? How does this impact the patient? How does this impact the environment? How do we ensure that everybody is safe? And in the end, if you've done that, if you've really identified what that risk is, what the vulnerability is, what the impact and the likelihood is, and really work through the issue, not the standard again, but the issue, you get to a much better place. The other piece is that I see where we dropped the ball at that point because a lot of times senior leadership is not involved in that risk assessment. So we created a way to get around a risk that was created by the lack of resources, the lack of people, lack of time, for whatever it may be, and said, yeah, we did our risk assessment, and then that's it. And the risk assessment is really the planning tool. It's the entry card to be able to have a meaningful discussion with leadership, impact budgets, and so on. So I think that that's kind of the genesis of where you and I kind of go sideways. I really promote the risk assessment, but I agree. It's like do them for meaningful stuff, not on the ticky tacky stuff.
Yeah, well, that I mean, I don't get me wrong, I'm not anti risk assessment. I just think it is something that should be used when first of all, it should be used when planning for a permanent correction if it's technically feasible. And then, I mean, everybody, especially life safety deficiencies, if it's something that requires construction, you're not going to fix that right
Cool.
away. Of course, there's a whole mechanism with interim life safety measures, and I keep using life safety, and so that's a little bit of its own thing. But something you mentioned, what's safe for the patients, what's not, maybe a better example of something related to temperature, humidity, or airflows and high risk environments or moderate risk environments. And so, to kind of bring Edwin into this conversation, we start talking about, I've dealt with a particular facility that struggled really for years in maintaining pressure relationships in their central processing department, on all sides of the equation, whether it's on the dirty side, the dirty side should be negative, the clean side should be positive, and they were flipping back and forth. And a lot of it was based on, I won't have to go into the details of what was causing it, but there was not an easy fix for that, right? So part of the response was, well, let's do a proactive risk assessment. And of course, as facility people, Skip and I can say, well, here's the engineering behind what's causing the problem and why we can't just snap our fingers and fix it. But Edwin, from your perspective, that's where we need that clinical experience and knowledge to chime in and say, okay, understanding that here are the other things that we think we need to do, which might involve testing and whatnot. But where do you see the clinical teams being involved in these risk assessments?
Unfortunately, and I think we've all experienced this, historically, we have not been good as organizations of involving everybody that needs to be involved. Clinicians, many times, even as a staff nurse, many years ago, I would push back, saying that the engineers are just getting in our way and interrupting patient flow, interrupting our workflow. But having matured in my career and at my last organization, I had the opportunity to not only lead nursing, but I also led the facilities team. So I wore several hats and had a much better understanding of why we've got to have those conversations so that from a airflow, from an infection prevention, and from a employee safety component, we all understand what the risks are. And I agree, Skip, with you and Steve, the risk assessment is just the planning card. It cannot be put on the shelf. It has got to be, okay, here is the risk identified. And we keep using the word risk. That means there's a problem. So once we understand that, then have that conversation with senior leadership to make sure that the resources are there to protect patients, the community, and the organization at large. When you bring in all parties and have that open conversation, solutions come in a little bit easier than what you may think.
Right.
Yeah. I
Yeah.
think one of the challenges that I've seen over time has been that as an industry, and I think even when in my early career when I was helping hospitals go through this process early on, it was, we treated them as static events or singular events rather than a dynamic event. And what I mean by that is, the risk changes over time, right? And an example I used to use often when I was teaching construction risk, and that's a whole different animal. And we should probably talk about that a little bit, but it's like, when you go through and you are working in a behavioral health unit, for example, that's probably one of the most challenging environments to work. And doing construction is, that the risk profile there can change literally every single second throughout the day. The only way that you're going to be aware of that is by leaning into your clinical colleagues and those people that understand that patient population and the risk associated not only to the patients, but to the staff and the people who are doing the work inside that department. Um, and so, man, that's a kind of an extreme example, but to me, it's a pretty good one.
Yeah.
So Skip, you like you
Yeah,
about to
and I'd even build on that. It's like, you can back it off from being that extreme, but today, I think primarily when we talk about ILSMs, you have to do the risk assessment. Virtually, I'm going to say everybody does a risk assessment at some point at the beginning of their project, whether it's in the PICRA or as they're moving forward with the project. But that's where it stops. So you have
right.
these huge projects, and it's like, yeah, we did our risk assessment, but the risk changed over time with moving into demolition, moving out of demolition, with the staging of supplies, the routes change and everything, and there's virtually no update to it. The activities change, but the risk assessment itself does not change.
Well, and to that point, Skip, and another component of the dynamic changes is, and we mentioned this in, I think, our last week's webinar, is as technology changes, the environment changes. I used the example of the OR last time, in which, we have gone from a very manual surgical process from a clinical perspective to robotics that create new machinery, new generations of heat. When the surgeon used to wear just a mask and a hood and a cap and a gown, now has to wear a hood that creates a 10-degree change. That's a new risk that needs to be assessed to evaluated to how do we balance the temperature and humidity and the environment in a dynamic nature.
Yeah, and Skip, you touched on something that I think is really relevant here. It's particularly related to construction. When you talk about pre-construction risk assessment, we mentioned PICRA. Um, that be is in a perfect scenario, it's the best examples I've ever seen is when that was done with an overlay of the project schedule. So there was a real understanding of the timeline and how that risk profile changes. And I remember years ago we spoke at APIC, thanks to Linda Dickey, who arranged that for, I think Tim Adams and I did that presentation. But one of the things that I did was I animated this sort of chart that showed the risk profile changing through each phase of a construction project. Demolition, it's going to be really high. Final fit and finish and punch out, that is pretty low. And where I see a challenges occurring with in terms of risk mitigation, and that's what we're really talking about, is the risk assessment is the first piece. The risk mitigation is what really matters. But with risk mitigation, particularly relative to construction, is we just apply sort of a blanket, one size fits all to the old project. So, which means there may be overkill at some level, and unfortunately not enough in some parts of that project. So, Edmund, I think you were about to say something too, or maybe I didn't mean to bypass you there, but so, part of what I think is really important here for folks to understand is that doing the risk assessment is the beginning of the work. In other words, we take and we look. Now, sometimes it can be the end. I mean, you can say, okay, we've looked at the risk associated with this issue. We've had the proper people involved, and we'll talk about that team makeup here in just a second, but we've had everybody involved. Everybody agrees that the risk is significantly small enough that we can go ahead and proceed and do what we want to do without making the change.
Yeah.
Flip side of that is someone on that team might say, wait a minute, this is a big deal. We need to take some kind of mitigative measures to make me feel comfortable about, whether it's staff, whether it's patients, whether it's visitors, or whoever the stakeholders are that they feel are at risk before we proceed. Does that make sense to you guys? You agree with that?
Yeah, absolutely. Absolutely.
Absolutely.
Yeah.
The thing that I see, where the other challenge I see sometimes, is who's involved in the process. I mean, typically, there's always somebody from safety involved. There's usually somebody from quality involved, because they're the ones that have to answer the question to the AHJs, whoever that AO might be, whether it's, DMV, Joint Commission, whoever, CMS, maybe it's a state, but they're not necessarily the right team, just those two, right? I mean, a lot of times you need that level of knowledge. Say we're working in the NICU, you need that manager, that clinical manager of the NICU who really understands that patient population, to be part of that process. Can you guys think of anybody else that might need to be in some of these?
Well, Steve, I would step back just a little bit on that and say that, as you're trying to determine who the team is, it it is critical that you define exactly what you're assessing. What is the risk that you're doing? Because too often we'll start out with, well, we're just doing a construction project. Well, that just sounds like I need a construction manager when you think about it. The
Yeah.
issue is that we are creating dust, we are creating noise, we're going to have water that's going in and out and so on, so that when you clearly lay it out, what is the risk to the patient and to the population and the building, it almost becomes self-evident who needs to be in the room with you to have that discussion. The other thing that I think I see a lot of times is the clinical side of the house, and this is not a disparaging comment, it's that on the facility side, we say we have to do this. This is a code. We have to, and for a clinician, that's blah, 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 because
Yeah.
it doesn't mean a whole lot. But when you can change that conversation to the risk to your patient is in doing this, then they want to be a bit more of the conversation and they get proactive about it. I mean, it's their patient now. And so they start to understand why we're concerned about it rather than jumping into the room and going, we did a risk assessment and you shall do this.
Yeah.
Skip, those are excellent points. A couple of other persons or groups to consider. They don't have to be involved every time, but in today's world, we have to consider them. Do we need to have security involved? Does the construction or does the environment create a potential security risk or a breach in protection? And then also the community at large, the patients, your patient and family support groups. If you're doing construction and creating different pathways and workflows, let's bring in the customer as part of that risk assessment. Do they feel safe? Do they feel comfortable? Is the egress more convenient or less convenient? So it is the quality, safety, clinicians, facilities, engineers, everybody involved for most of these items.
Yeah. One of the more common uses of risk assessments lately has been related to equipment. Well, there's two that we keep getting questions about. One of them is equipment maintenance, medical equipment maintenance in particular, where the manufacturer's recommendations might be, something pretty extreme, and there's a question as to whether it's appropriate for there to be a reduction in how often certain things get done. I don't want to get specific examples because I don't want to, pin it on anybody. That's one of those conversations where, yes, the clinical engineers can say, this is why we believe it's safe to change it from monthly to semi-annually. But it's absolutely imperative from my perspective to get the clinical buy-in on that, whether they, they may not have a technical position, but whether they feel comfortable with that. The folks that I think probably need to be involved in discussions like that are risk management. Uh,
Mhm. Yeah.
so yeah, that's one of the ones that we're seeing pretty often. And I think one we probably talked about in the past during one of these episodes was related to if you decide to take the waiver for reduced humidity, um, then you've got to basically do a risk assessment on any items that are stored in those spaces from that 30% down to the 20% and document that. And that's really kind of a moving target.
Right.
It's difficult to do because those products change. But it's probably worth mentioning that a lot of those instructions and guidelines are written not by engineers, but by attorneys and risk managers for the manufacturers. And it was really easy, especially when the standards were to, you couldn't go below 30% relative humidity in these spaces, to just say, well, that's our storage standard, our
Mm,
operational standard, without really having to go in to do a whole lot of science behind it. But so any other thoughts about those things in general? I mean, I know we've all seen them here lately.
I think again, it's just a reminder for our entire audience, don't use the risk assessment as an endpoint. Use it as the beginning, and bring in the right team members. Back to Skip and Steve's points, look at the proactive component. Take a step back. Who's going to be impacted? How is the community going to be safer? How is the patient going to be safer? And how are your employees going to be safer?
Right. Yeah.
Yeah. Well, and Ed, when you touched on something that I think is where a lot of these are getting generated, I guess, right now, and that's security versus life safety, basically. And those are oftentimes at odds with one another right now. I mean, from a life safety perspective, egress is king, and it should be, right? I mean, we want to make sure people have the ability to get out of a facility that they're in danger in, whether that's from fire or some other source. Which is one of the more challenging things. I mean, I know Skip and I have been involved in more debates than we care to think about with folks at hospitals about locking doors in the path of egress, and you know all of the requirements associated with that and how you can't really do that. Um, but from a security perspective, sometimes you just about have to, and so that's a really good um, example, I think, an opportunity for having that sort of framework of, hey, we're looking at two sets of risk, and we're living in a fully sprinkled building that's well maintained, that's relatively new, that's got fire detection, fire suppression, all these things. But we also are in an environment with increasing security risk. So where as an organization do we land? Now, that whether or not that's going to fly with every AHJ that's out there, it's hard to say. I mean, some will say, yeah, that's an acceptable situation to us, but in doing so, there's going to be some mitigative strategies that have to be applied, like staff carrying keys. I mean, there's all kinds of different things that have come into play, and from a code requirement, the life safety code is the king, and they are very specific. But certainly things like security versus traffic control, those kinds of things, that's a great example when you could apply risk assessment. The thing is it's you don't want to be doing them after the survey. You want to think about what are they,
Right. Yeah. Yeah.
you want to do them
I'm
before the
pretty sure the
survey.
horse is out of the barn by that point. Yeah.
Yeah, it's a little too late. I mean, it's you could do it as a part of an ESC or a response,
Right.
for DMV, but you're better off going ahead and address. If you know you've got the issue, address it in advance, and have that ready to pull out. The best thing that I can, even though the Joint Commission kind of went away from the requirement to have an environmental care committee and all that stuff. Well, here with the A360, I still think it's absolutely um, important to have that multidisciplinary team. and keep documentation and minutes. And one of the things you'll want to do is, and you've identified there's an issue. Let's do the proactive risk assessment. Let's document that discussion in the minutes and whatever resolution that came from that discussion, so that when that time, you're in that meeting with the AHA, whoever they are, and they're saying, okay, you've got this problem. So, well, here's how we address that. We addressed it proactively. We brought, this was the team. We had, risk manager. We had infection preventionist. We had the department head. We had the facilities. We had clinical engineering and security, and we all agreed that this was the proper path. And here's that documentation. I think that to me is really, really important. Any thoughts about that?
The thing that I would add to it, Steve, I agree with everything you said. I think as an organization, you have to decide how you're going to do your risk assessments, that they're standardized and they're defensible, that you have consistent scoring, you have a defined scoring criteria, you have categorizations such as like safety, infection control, and then you have established thresholds for how you're going to do that. I would also add to that that you should have consistency in how you report these, based on just how important it's viewed by the group that's doing it. And this goes back to my earlier comment about ensuring that leadership is aware that this is the route we're taking. We know this is not completely acceptable to all AHJs out there, but based on our experience, our observations, and what
Yeah.
we're capable of doing, this is what we're going to do, and have leadership opine on how long are we going to do that.
Yeah.
Well,
No,
and,
that
and
you're
to your point,
go ahead.
and to your point, Skip, when you say leadership, make sure you're being inclusive. That includes medical staff leadership. It includes
Yes.
financial leadership, operations leadership, and at least information to the board at issues that may require funding or other community risk.
Yes. Totally agree.
Yeah. And, I think it's important. There's no guarantees that doing a risk assessment is going to avoid a citation from your accrediting organization or CMS, but it's better than nothing. Here's one example, and not that I would ever, this is totally hypothetical. I'm not sure that I would go here, but, let's say, for example, you build a brand new OR and you've started operating, and when you get in, you start testing, it should be 20 air changes per hour. You're only getting 18. And you do, after going through all the commissioning docs and talking with the engineers, there's just no way to get to 20 without making some significant changes. It's going to take a while. That would be a good opportunity from my perspective to have more of these proactive risk assessments where you bring in the physicians, you bring in infection prevention, you bring in everybody, and you say, okay, we're 2 air changes short. We've got good filtration. But my point of this is, once you've done that, to me, the most important part of this is then maintaining a high level of observation for infections in the sites that are affected by this, so that you can prove, hey, okay, we made a decision, an informed decision based on the fact that we're 2 air changes short in these rooms. We've been monitoring for hospital or surgical site infections in these spaces. We're not seeing a significant difference in there versus anywhere else in the OR. So we believe we're in good shape. That you guys agree with that as well?
Absolutely.
Absolutely.
'Cause that's the one thing we haven't really talked about is how do you prove you made a good decision, and the way to do that. There's certain things that, well, hey, we decided to not fix whatever this little deficiency is. I certainly wouldn't build a whole, um, measurement tool around something like that. But the example that I just gave, where it's going to be an ongoing performance kind of thing, or for, temperature and humidity, or for, I'm trying to think of other examples, but those kinds of things, I absolutely would have some
Well,
type of monitoring proactive that you were presenting that information back to that environment care, whatever committee makes sense. It might be an infection control. It might be, as Edwin mentioned, it might be the board, depending on how big an issue it actually is.
Yeah.
So
This is
and
actually, I mean, once you do the risk assessment, it's the old PTC model. You've planned for what you're
Yeah.
going to do. Now you're doing it. You need to monitor it, change it as you're monitoring, and then re-implement it. And I think on the front end of that, it's communicating what's out there and the education piece to ensure that it's happening. But I will say right now, I've had more instances of reliance on others. So whether it's in construction, it's the contractor, whatever, to kind of monitor what's going on. Um, a- it's a mistake. I'll just say it straight
I'm
out.
not,
It's
that's
a
not,
mistake. You're handing the keys over and you're still responsible for locking the door. So
Exactly.
I just be
yeah.
real careful about that.
Yeah, I mean that's true in so many instances, particularly in the construction environment, and I think one of the reasons that remains the same is because hospitals, as a general rule, do very little construction. I mean, they may feel like they're always doing it, but it's not their core competency. So they say, look, they bring in contractors and say, hey, we're going to let you handle all this and you do it. But you're right. I mean, that's a great analogy. You give them the keys, but it's still your responsibility to lock the door. You give them the responsibility for maintaining and monitoring the performance of the mitigation strategies, but are still your patients to protect.
Right.
And yeah, that's a whole nother episode. Planning, I'm planning to insert some things into Edwin's schedule that here, and one of them is going to be
Good.
related to construction monitoring, because I think I'm seeing some challenges with that. Getting a lot of questions still. People calling and saying, "Hey, what should we do? Should we do this or do that? Do that?" And compare it to what is done in other places in the world from a construction perspective. We're kind of way behind. I hate to say it, but you know, not that I would suggest that we go over the top in every single project. That when we're doing high risk environments, we really have to think through what we're going to do and how we do it, and who's involved. So, gosh, this time went by really fast. We're kind of running up on the timeline here. You guys have any other thoughts, questions?
No, I think we've covered a good amount of
Yeah.
information. Again, remember, keep the focus on zero harm.
Yeah.
Yeah. I mean, that's what it's really all about, right? It's, you just kind of look and say, okay, here's what we got. What can we do to make the best of it? I mean, that's really what a risk assessment is. And
Yeah.
if it doesn't make sense, then we just have to say, okay, we gotta stop. We gotta stop for now. We gotta fix the problem. Um, you know, I know there's huge pressures to maintain revenue streams, and you never want to stop and provide access barriers to care. But on
Right.
the flip side, you don't want to create unacceptable risk in doing that. So, that's the formula, if you will. So,
Yeah. Totally agree.
well, well, guys,
Very
I
good.
certainly appreciate your time and expertise as always, and I appreciate you all joining in and watching today. If you've got, again, any questions, we'd love to get them in the Q&A, and if we didn't answer them already, we'll answer them going forward. We'll try to get to you through email. Again, if you're accreditation readiness network member, easy for me to say, make sure to reach out to us and we'll get those CECs for you. So thanks again, and we'll see you all in the next one.